Hello friends, today we are going to discuss this question which was asked in DRNB Critical Care Exam June 2022. So the question was regarding the intra-aortic balloon pulsation. So we'll see what is basic principle of IBP. So the counter pulsation is the term that describes the balloon inflation in diastole and deflation in the early systole. So balloon inflation causes the volume displacement of the blood within the aorta, both proximally and distally. This leads to the potential increase in coronary blood flow and potential improvement in the systemic perfusion by augmentation of intrinsic Wien Kessel effect, whereby the potential energy stored in the aortic root during systole is converted into kinetic energy with elastic recoil of the aortic root. Now let's see what is the physiological effect of the IBP. The primary goal of the IABP treatment is to improve ventricular performance of the failing heart by facilitating an increase in myocardial oxygen supply and decrease in myocardial oxygen demand. The overall hemodynamic effects of IABP therapy are summarized in the table. So, summary of hemodynamic effect of IBP therapy. In aorta, there will be the decrease in systolic pressure and increase in diastolic pressure. Then in left ventricle, there is decrease in systolic pressure, decrease in end diastolic pressure. There will be decrease in volume and decrease in wall tension. Then in heart, the effect will be decrease in afterload, decrease in preload, and increase in cardiac output. And the blood flow will be increased coronary blood flow. Although these effects are predominantly associated with enhancement of LV performance, IBP may also have favorable effect on the right ventricular function by complex mechanism including accentuation of the RV myocardial blood flow, unloading the left ventricle, causing reduction in the left atrial and pulmonary vascular pressure and RV after. So IBP inflates at the onset of diastole, thereby increasing diastolic pressure, and deflates just before systole and reducing LV afterward. So the magnitude of this effect depends upon balloon volume, that is the amount of the blood displaced in proportion to the volume of the balloon. Then heart rate. LV and then aortic diastolic filling time are inversely proportional to the heart. So shorter diastolic time produces the lesser balloon augmentation per unit time. Then aortic compliance. As aortic compliance increases, the magnitude of diastolic augmentation decreases. Now regarding myocardial oxygen demand and supply. Inflation of the IIBP during diastole increases the pressure difference between aorta and the left ventricle, the so-called diastolic pressure time index. The hemodynamic consequences of this is the increase in coronary blood flow and therefore myocardial oxygen demand. So the myocardial oxygen demand is directly related to the area under LV systolic pressure curve termed as tension time index. Balloon deflation during systole causes reduction in the LV afterload and decreasing this tension time index. Thus, the ratio of oxygen supply to the oxygen demand, known as endocardial viability ratio, should increase if the IBP is working optimally. This can be evidenced by increase in the coronary sinus lactate. Then let's talk about the coronary perfusion. According to the Hagen-Poisson principle, flow through the tube is directly proportional to the pressure difference across it and the fourth power of the radials, while being inversely proportional to the length of tube and viscosity of the fluid flowing through it. Hence, in patients with the severe coronary artery disease in whom autoregulation is perceived to be absent, coronary blood flow is directly related to the diastolic perfusion pressure. Therefore, IBP should theoretically improve coronary flow in this patient. Now, regarding renal function. Renal function flow can increase up to 25% secondary to increase in cardiac output. So if there is a decrease in cardiac output after insertion of IBP, then that should raise the suspicion of juxtarenal balloon position. Now regarding hematological effect. The hemoglobin level and the hematocrit often decrease by up to 5% because of hemolysis from mechanical damage to the end blood cells. Thrombocytopenia can result from mechanical damage to the platelet and heparin administration or both. So we'll see what are the indications and contraindication for the use of IB. So indications are acute myocardial infarction, cardiogenic shock, acute MR, VSD, catheterization, angioplasty, refractory unstable angina, refractory heart failure, refractory left ventricular failure, refractory ventricular arrhythmia, cardiomyopathy, sepsis, infant and children with complex cardiac anomaly. Then cardiac surgery weaning from cardiopulmonary bypass. Contraindications are absolute contraindication include aortic regurgitation, aortic dissection, chronic left end stage heart disease with no anticipation of recovery, and aortic stent. And relative contraindications are uncontrolled sepsis, abdominal aortic aneurysm, tachyarrhythmia, severe peripheral vascular disease, and major arterial reconstruction surgery. So, acute myocardial infarction. IABP is aimed at achieving hemodynamic stability until definitive course of treatment and recovery occurs. By decreasing myocardial work and systemic vascular resistance, intracardiac shunting and mitral regurgitation, or both, are reduced while coronary perfusion is enhanced. Severe mitral regurgitation secondary to the papillary muscle dysfunction or rupture after myocardial infarction can lead to significant hemodynamic instability. This can initially be managed by IBP pending definitive surgery. Now, regarding ventricular arrhythmia, IBP is also effective in stabilizing patients with refractory ventricular ectopy after myocardial infarction by increasing coronary perfusion pressure, reducing ischemia, and then transmyocardial wall stress and maintaining adequate systemic perfusion. Regarding cardiogenic shock, this is the life-threatening complication of acute myocardial infarction, and it is characterized by the low cardiac output, hypotension, unresponsive to fluid administration, elevated feeling pressure, tissue hypoperfusion leading to oliguria, then hyperlactemia and altered mental status. And IVP is considered to be the class 1 indication for management of cardiogenic shock, not rapidly reversed by pharmacological therapy. Now about unstable angina. Unstable angina refractory to the drug treatment is an indication for IVP. So these patients, they are at increased risk of developing acute myocardial infarction and death. So by improving hemodynamic condition of these patients, IVP can facilitate further percutaneous intervention or bridge the patient to the surgery. Then refractory ventricular failure. IVP has also a role in managing patients with refractory ventricular failure outside the setting of acute myocardial infarction, such as those with cardiomyopathy or severe myocardial damage associated with viral myocarditis. This can aid the progression to more definitive treatment, such as ventricular assist device or cardiac transplantation. Now about cardiac surgery. IBP is used for stabilization of patients with acute myocardial infarction referred for urgent cardiac surgery. So IBP support is often initiated in cardiac catheterization lab or continued through perioperative period. Elective placement is considered in high-risk patients such as those with significant left main disease and severe LV dysfunction, congestive heart failure and cardiomyopathy, chronic renal failure, or cerebrovascular disease. So, weaning from cardiopulmonary bypass may be difficult in cases where aortic cross clamping is prolonged and revascularization is only partially achieved, or pre-existing myocardial dysfunction is present. So, separation from cardiopulmonary bypass may be marked by hypotension and a low cardiac index despite administration of inotropic drug. The use of IVP in this setting decreases LV resistance, increases cardiac output, and increases coronary and systemic perfusion, facilitating the patient's weaning from cardiopulmonary bypass. Now about contraindication, it is contraindicated in patient with aortic regurgitation because it worsens the magnitude of regurgitation. IBP insertion should not be attempted in case of suspected or known aortic dissection because in adherent balloon placement in the false lumen may result in extension of dissection or even aortic rupture. Similarly, aortic rupture can increase if IABP is inserted in patient with sizable abdominal aortic aneurysm. So, patient with end-stage cardiac disease should not be considered for IABP unless bridge to ventricular assist device or cardiac transplantation. So, IABP device placement should be avoided in patient with severe peripheral vascular disease. Percutaneous femoral IABP device insertion is contraindicated in presence of bilateral femoral popliteal bypass graft. Uncontrolled sepsis and bleeding diathesis are relative contraindication to placement of IBP device. Now the complication associated with IBP. Transient loss of peripheral pulse, limb ischemia, thromboembolism, compartment syndrome, aortic dissection, local vascular injury that is false aneurysm, hematoma, bleeding from wound, infection, balloon rupture, balloon entrapment, hematological changes like thrombocytopenia, hemolysis, malposition causing cerebral and the renal compromise, and cardiac tamper. Now, technique and insertion. So, IVP device has two major components. A double lumen 8 or 9.5 French catheter with 25 to 50 ml balloon attached at its distal end. The console with the pump to derive the balloon. The balloon is made up of polyethylene and is inflated with the gas driven by the pump. So the helium is often used because its low density facilitates the rapid transfer of gas from console to the balloon. It is also easily absorbed into the bloodstream in case of rupture of the balloon. Before insertion, the appropriate balloon size is selected on the basis of patient's height. So, as supplied by the data scope, for patient with the 152 centimeter in height, the balloon volume of 25 cc is appropriate. And for height between 152 to 163, balloon volume of 34 cc. For height of 164 to 183, appropriate balloon volume should be 40 cc. And for height of 183, balloon volume should be 50 cc. Smaller balloons are used for pediatric patients. The diameter of balloon when expanded should not exceed 80% to 90% of diameter of the patient's descending thoracic aorta. The IBP catheter is inserted percutaneously into femoral artery through introducer sheath using modified Seldinger technique. Alternative route of access include subclavian, axial, brachial, and iliac artery. The catheter also be inserted surgically using transthoracic and translumbar approach, but this is associated with increased periprocedural mortality. Once vascular access is obtained, the balloon catheter is inserted and advanced, usually under fluoroscopic guidance into descending thoracic aorta, with its tip 2 to 3 centimeter distal to the origin of left subclavian artery. Intraoperatively, balloon placement can be ascertained using transesophageal echocardiogram. The outer lumen of catheter is used for the delivery of the gas into balloon, and inner lumen is used for monitoring systemic arterial pressure. Console is programmed to identify trigger for balloon inflation. So most commonly used trigger are ECG waveform and the systemic arterial pressure waveform. The balloon inflates with the onset of diastole, which corresponds with the middle of the TV, and balloon deflates at the onset of LV systole, and this corresponds to the peak of the arc. Poor ECG quality, electrical interference, and cardiac arrhythmias can result in erratic balloon inflation. So balloon is said to inflate after aortic valve closure and deflate immediately after opening of aortic valve. So IBP timing refers to the inflation and deflation of the IBP in relation to the cardiac cycle. So the cardiac cycle is monitored by continuous display of aortic pressure wave. As balloon inflates at the onset of diastole, sharp and deep V wave is observed at diacritic notch. Balloon inflation causes augmentation of diastolic pressure and second peak is observed. This peak is referred as diastolic augmentation. So diastolic augmentation is ideally higher than the patient's systolic pressure, except when reduced stroke volume causes a relative decrease in augmentation. Depending upon the patient's hemodynamic status, the balloon is programmed to assess every bit or less, every bit that is 1:1 or less often, that is 1:2, 1:4, or 1:8. With hemodynamic improvement, the device can be weaned to less frequent cycling before complete removal. However, device should never be left unused in situ to prevent thrombosis. So this is the diagrammatic representation that is which explains the inflation which occur at the onset of diastole. So when IBP inflation occurs, it is giving rise to sharp P wave on the arterial wave. And when inflation occurs, its effect is to increase coronary perfusion. Now, when the deflation occurs, which occurs at the end of diastole, that is before systole, resulting into the reduction of aortic end diastolic and systolic pressure. And the effects are decreased afterload, decreased cardiac work, decreased myocardial oxygen consumption, and increased cardiac output. Now, this is the oh, so as shown in the diagram, A represents the one complete cardiac cycle. B is unassisted aortic end diastole pressure. C is unassisted systolic pressure. D is diastolic augmentation. And E is reduced aortic end diastolic pressure. And F is reduced systolic pressure. So suboptimal timing. So whenever there is a difference in this timing of inflation and deflation. So that results into the that results into the impairment of the balloon function, which results into the hemodynamic instability. For example, early inflation. So inflation of the if this inflation of IBP occurs before aortic valve closure, late inflation means inflation is occurring after the closure of aortic valve. Then early deflation. There is a premature deflation of IBP which occurs during diastolic phase, and late deflation means the deflation of IBP after onset of systole. So this is the diagrammatic representation of malfunction, that is A. A represents the inflation of IBP before diacritic notch. B means inflation of IBP after the diacritic notch. C represents the deflation of IBP, which is seen as sharp decrease after diastolic augmentation. So weaning from IBP should be considered when there is enough inotropic requirements are minimal, thus allowing the increased inotropic support if needed. Then weaning is achieved gradually, reducing the ratio of augmented to non-augmented beat from 1:1 to 1:2 or less, or decreasing the balloon volume. Balloon should never be turned off in situ except when the patient is anticoagulated because of the risk of thrombus formation on the balloon. Patient's care should be carried out with the three primary goals in mind. Evaluation in terms of hemodynamic status, systemic perfusion, and relief of cardiac symptoms. Observation for early signs of complication, including limb ischemia, balloon malpositioning, thrombus formation, bleeding, and infection. Ensuring proper position of IBP, including correct timing, consistent triggering, and troubleshooting of the alarm. Thank you, guys.